So if we look at our pyramid, the cohort studies falls underneath the randomized control trials. And this is why this Murad version is good. So just because it's a cohort study doesn't mean it's worse than a randomized control trial. So some of the most important findings we've had in scientific history have come from cohort studies, and there's some really impressive ones that are underway at the moment. And I'll just start off today's lecture by talking a little bit about them. So don't worry too much about that figure, there's a lot going on there. But if you do get confused by what prospective cohort studies are down the track and you want to come back and have a look to see which type they are, I think that figure's quite good. Essentially what you need to know with a prospective cohort study is it's the researchers begin the study before the disease or thing of interest is typically observed. So if you think of it as being like if we want to look at who develops something over time, that would be a prospective cohort study where we assess a whole bunch of people and then see what happens to them over time. So if you wanted to see, for example, who develops heart disease, you could get a bunch of university students or who don't have any heart disease, monitor them over 30, 40 years. And if some of them get heart disease, then look at the different things that might have contributed to that heart disease. So a prospective cohort study is very powerful. And that's when we have the question at the start. So we're not trying to look back in time, we're trying to look forward in time. So we have the question, we identify people that we can put into the study and then look and see if they develop it, the clinical condition over time. And that's what we call a prospective cohort study. One of the real powers of it is that we can design the study to be quite rigorous from the start. So I will talk about some of the more famous prospective cohort studies for the start of this lecture, just to put in perspective like what these sort of things do. So arguably the most famous one is called the Framingham Heart Study. So it's been going since 1948. So that's a long time. There's 15,000 people spanning 3 generations of the same families, which is really quite impressive. And a lot of the stuff you read about with genetics, so, this gene might predict this outcome, that comes from this Framingham Heart Study. There's also been a lot of interesting things from it, like, for example, if your great-grandparents ate something or smoked something or did something, how that's impacted on your genes. And the reason they've been able to do that is because they have these longitudinal data in multiple generations of people. Another one which is probably particularly relevant for many of the students in this class is the Nurses' Health Study. So when it started, it was only women. It's just the most recent phase where they've included men into it as well. But that's over 275,000, predominantly women, from 1976 to now, where they track their health outcomes over time. So that's given us some really important information about changes in women's health as they age. And then the big one, which I think is particularly relevant, is the UK Biobank study. So it started in 2006, and again, it's still going. And it's had over 500,000 people. And one of the interesting things about this is they allow anyone to access their data to crunch some numbers on it. And it's also linked to the medical records. So it's a very exhaustive data set. So just quickly on the Framingham Heart Study, this one, anyone who sort of does clinical research or has anything to do with epidemiology knows this one quite well. So what the original researchers did, they took 20% of a small town in upstate New York, and they did some cluster sampling by family, which was really quite interesting. So essentially what that means, and we haven't mentioned cluster sampling before, but essentially they took a bunch of families. So instead of randomly picking people, like say a dad from this family, a mum from another family, a kid from a third family, they've gone basically different households and taken them. It's a little bit slightly off topic a bit, but one of the interesting things that's happened with the science is they didn't originally intend to do that. They originally intended to randomly sample from a cohort, but the townspeople actually said, well, you can't do it unless you take from families and take everyone in the family, because they thought it would be too disruptive. So the researchers actually didn't want that at the time, but now looking back, it's the best thing that could have happened. So these are the things that can pop up weirdly in research sometimes. So by taking those families and following those families over the generations, they've been able to get all that really interesting genetic information. And they've looked at it from people aged 28 to 74. They're the people when they enroll into the study, and they monitor them all the way through to eventual deaths. So one of the key things about the Framingham Heart Study is they're looking at heart disease. So they made sure that they were free from overt cardiovascular disease. So don't stress about reading all the words on this, but essentially this just puts a bit of a frame around the Framingham Heart Study. So they started in 1948 with some, very sort of basic assessments. And then as the years went on, they started adding things in. So when things like MRI was invented and computerized tomography, they added that. They started doing exercise testing, blood testing, all kind of like genome assessments. And they've been able to do that over time, which has been quite fantastic. So every second year, the people involved in the study would come and do all these exhaustive tests and allowed them to be monitored throughout their lifespan. So what did they find? And this is where it comes back to some of the things we've spoken about before. So back then, people thought that doing physical activity increased your risk of heart disease. It was assumed that actually exercise was a bad thing, and therefore the more exercise you did, the more likely you were to have a heart attack. So when the original studies came out of the Framingham Heart Study and showed that physical activity actually appears to reduce the risk of heart disease, they were kind of rubbished because they were considered to be illogical. But obviously now we kind of assume that physical activity is a good thing based on all the evidence that's out there. The evidence is really strong. Simple things we take for granted now, that blood pressure is related to stroke, wasn't known before the Framingham Heart Study, obesity being a risk factor for heart disease, and genetics playing a role in heart disease. None of this would have been known had it not been for longitudinal studies like the Framingham Heart Study. So that shows you some of the impact these longitudinal studies can have. Then there's the Nurses' Health Study, which again is a really, really important longitudinal study. So this is where nurses were chosen because of their knowledge of health and the ability to provide accurate information. So the researchers wanted people who could, validly fill out these forms on health response. So they picked nurses. So they had to be married, I don't know why, registered nurses aged 30 to 55. And an important thing, as we mentioned last week in the lectures and shoots, 71% of the people they contacted became enrolled in the study, which is an outstanding response rate. So it makes it really generalizable to, that sort of age group of nurses. So originally they had 121,700 people in it, which again is a lot of people. And it's had a huge impact on women's health. And just to put it in perspective, a lot of the things we know now about cigarette smoking and its relationship to things like bone density, cognitive function, eye disease, that was all found out from the Nurses' Health Study. And some of the really interesting stuff about postmenopausal hormone therapy and the use of oral contraceptives, again, all came from this study. And it's really quite fascinating. So some, oral contraceptives, for example, it reduces the risk of some things, it increases the risk of others, same with postmenopausal hormone therapy. So much of that information we just never would have found from things like randomized control trials because you just couldn't recruit enough people to do a study like that. So again, this has had a really big impact on people's health. And last and definitely not least is the UK Biobank study. So it is definitely the most ambitious longitudinal cohort study ever. And it has exhaustive data collected on more than 500,000 people linked to their medical records. And again, as I mentioned before, it's open to any researcher to analyze their data. Now, there is the potential for massive impact on healthcare and some really interesting findings. Like one of their papers showed that grip strength, as I mentioned before, I think in a previous lecture, is a better predictor of future cardiovascular disease mortality than blood pressure or physical activity levels. So they're the sort of findings which, again, don't seem logical, but given the number of people in the study and the rigorous nature of the research, it becomes really, really quite interesting and really potentially impactful for healthcare. And then a really simple walking question about how fast they walk. Do you walk the same, faster or slower than other people your age? Has been shown to be one of the best indicators of future mortality. So it's been able to guide healthcare in a way that probably may not have seemed directly straightforward in the past. So now asking people about their walking speed or measuring the walking speed is becoming a lot more important and done more worldwide than it used to be based on these sorts of studies. Now, the UK Biobank study, I think, is a really good one because it is a glimpse into the future of healthcare and in particular, allied health staff's future in healthcare as well. And this is what eDoc systems are designed for. So electronic documentation it's well suited to this. So even like, 2-3 years ago, most hospitals, if you went there as a patient and you were assessed, your results would get written on a piece of paper and unfortunately put in a filing cabinet, possibly never to be seen again. So if a hospital actually had a database, it was usually done at, say, a department level. So the Department of Occupational Therapy would have their own Excel file with some patient data in it that was randomly filled out and hopefully regularly filled out. But usually if we'd actually look at those sorts of databases, we'd find there was quite a few holes in them. And, you know, most of the databases I've seen are from, you know, tertiary hospitals, large hospitals with people who know about research. So in smaller hospitals and private practices, the odds of those data being all that useful are probably low. Whereas now these eDoc systems, electronic documentation, they are forcing everyone in the hospital to put all their data into a centralized space, which is run by IT professionals who check and verify that data is being put in properly. So that the UK Biobank study is very similar to that in that it was able to get everyone's data in one place. But that's what that's what hospitals are going for now. They want their own UK biobanks and they want to be able to link up with other hospitals to create bigger data sets. The key thing about this is that all the big companies are getting involved. So Project Nightingale is Alphabet, which owns Google. So they have links with many hospitals throughout the United States and run their databases for them. So Google controls their databases and they can link it up with their data. So if you don't know much about Google and Alphabet, they own a lot of companies you'd be surprised to know they own. So they own things like Fitbit, for example. So now we're getting to the stage where the hospital records could be linked with all the information about their web searches, with all the physical activity they're doing, with all the things they're going to see and do, and all the restaurants they're visiting, and all this sort of information is becoming centralized. And Google also has strong links to the Mayo Clinic. So hopefully you all know what the Mayo Clinic is, but that's the premier hospital system in the world, based in Rochester in America. So the Mayo Clinic is considered the flagship hospital in the world, and they have partnered with Google to control their medical databases. So, and this stuff is accelerating very quickly. And the reason being is that medical data may be the most valuable resource on the planet. If you think of every single drug that's out there, every single person who wants to live longer, all the costs of healthcare to the world, all of this is influenced by the medical data. So if companies like Google can get involved and be ethical about it, this could have some fantastic outcomes for people. And it won't be randomized control trials. It'll be longitudinal cohort studies. So in millions and millions of people, what leads them to get rare diseases? That's where it'll be very powerful. So the good thing for OTs, they are a logical best fit for the front line of data collection. As I might have mentioned before, but you know, I don't know which allied health staff spend more time with patients or clients, as whichever one you want to call them. Maybe physiotherapists, possibly, but I don't even know about that. So particularly in things like community rehab, when you're out in private practice seeing people, like UOTs will be a logical fit for that. So there's a good chance that you'll be required to input data well and link up with outside data sources. There's one thing I can pretty much guarantee, it's that where you work will be doing some form of longitudinal cohort study, some form of prospective. So if you get to see a client and they come in, then wherever you work, they will be monitoring them to see, you know, do they keep coming back? Do they leave? If they leave, why are they leaving? So this is the sort of stuff that you'll see quite often. It may not be called a prospective cohort study, but you will be involved in one. So the pros of the prospective cohort study is that it's an excellent method for answering research questions in situations where intervention trials are not feasible. So we've spoken about the smoking thing before. So you can't do a randomized control trial where you get healthy people to start smoking. Like, that's just unethical. But you can look and see if healthy people who start smoking have worse outcomes down the track. And another pro, it's answered some of healthcare's most important questions. Now, it does have cons. So a con is that it's near impossible for rare diseases without strong predictors. So if you think of something, example might be, say, Huntington's disease, which is really quite nasty, only affects somewhere between 1 and 4 per 100,000. To do a longitudinal cohort study would be very difficult to do if you just sampled on a wide basis. So there's many other diseases like that, you know, motor neuron disease, a lot of things like that, where it's just prospective cohort studies are next to impossible without millions and millions of people involved. It's not well suited to new or novel conditions. And for these, we need retrospective cohort studies. So the first one was prospective, where we got a bunch of people to look to see if they've developed something. A retrospective cohort study is when we look at people who have something and then try and go back in time to figure out why they got it. So the researchers begin the study typically after the disease or thing of interest is observed, and then they need to go back and mine prior data. So this example here, again, don't stress out, there's a lot of arrows and stuff there, but you can come back and look at that down the track. Is an example of, think of people working in a tire factory and they develop some respiratory diseases. And you wanted to figure out why, or, was it actually the tire manufacturing that caused it, or was there something else? You would go, okay, we have these people with respiratory diseases and other people from the same workshop, for example, that don't have it, and look back in time and see, okay, are the people getting the respiratory diseases all, working closer to the plastic fumes? Or is there some other factor involved there as well? And that's where they can use that information to go, okay, while we can't do a randomized control trial, we can get a good idea if these tire fumes are actually causing the problem. A classic example of that, which is very Australian, is asbestos. So hopefully you all know about the dangers of asbestos. It causes basically its own type of cancer. I can't really say it, mesothelioma, I think. But essentially, look, there was no randomized control trials done for this. There was no prospective cohort studies to identify that this was the problem. What happened is they started to see a whole bunch of people who started developing these nasty cancers, which have very high, well, I think 100% fatality rates actually, in a very short amount of time. And they realized that something must have been going on, started to do some, digging into the data and realized that it seemed to be related to this, fiber sheeting or asbestos. So they did retrospective cohort studies to look back and go, okay, who's getting this type of cancer and are they different from others? And they were able to identify that, yes, it was this asbestos that was causing it. So they were able to basically ban that in the 1980s. And now it's, you can't use that in building anymore. It still exists in a lot of old homes, but they can't use it. So that was the power of a retrospective cohort study. You couldn't have done a prospective one with that because usually it takes for asbestos, about 30 years to develop into cancer, the exposure. So to do a prospective cohort study over 30 years, you'd imagine how many people would have died along the way. Whereas the retrospective allowed people to go, okay, we're noticing this, what can we do? Or what can we find out and stop it straight away? My concern is the replaced tire manufacturer 3D printer users now. There's a lot of people using plastic filaments and 3D printers, which are carcinogenic and not realizing it. So if you do get around 3D printers, make sure you ask those sorts of questions because they are getting more and more prevalent in hospitals. So probably the best example I can give of retrospective cohort studies other than asbestos is one of the most impactful research studies probably of your lifetime. So this study started at the end of 2019, start of 2020, when researchers in China started asking, why are we seeing all these respiratory illnesses ending in death? So the hospitals over there started noticing a lot of people who would come to hospital and die from something which looked like an extremely nasty version of flu or bronchitis. So they basically went, something's wrong here, what can we do? So they started a retrospective cohort study to look at what was influencing the outcomes of the people presenting with this new disease. So they were able to identify that the people who had this condition had this specific disease or virus, COVID-19, and were able to go back and go, okay, all the people who come to the hospital with this, who is surviving and who's not. So going back through their data, so retrospectively looking through the data that they had, they could look at the medical records from everyone who tested positive and identify the factors that were more likely to result in poor outcomes. So those results were published at the end of March 2020 and looking at the risk factors for mortality in people with SARS-CoV-2, i.e. COVID-19. So that is one of the most important and most influential studies of our lifetime, and it was done in about 3 months. So this shows the power of a retrospective cohort study. It was published in arguably the best medical journal, and it provided evidence of risk factors, how long people are infectious for, the outcomes of treatment strategies, etc. And it informed, or unfortunately for many countries, should have informed the way the world reacted to this novel virus. So we could look at those data and go, this is scary. It's killing a lot of people. It's killing a lot of people based on age. So they have their odds ratio there. Again, you'll see their confidence interval. So we could see for every year extra in age, then your risk of dying went up by 1.14 times. and they had some cut points. As soon as you're over the age of like 65 to 70, then your risk of dying goes up dramatically. It was a relatively small sample size, given it was basically the start of the outbreak, but they were able to provide points in the direction of, females are less likely to die than males. People with coronary heart disease are far more likely to die than people without it. And diabetes is a risk factor, hypertension is a risk factor. So they were able to basically inform the other healthcare systems and their own healthcare systems about what to look for people who are at high risk. So that was an absolute cracker of a paper, and it helped to provide evidence at a time. And if you remember March, April last year, like no one really knew what was going on. We had all these nightmare stories, and we'd hear things like, all the children are going to die and all these things. Thankfully that didn't happen. But by doing this retrospective cohort study, we could get some great information and know what we needed to know to at least kickstart the way it was treated. So I've just seen Emma pop up in the chat. Cohort was limited to married women due to the sensitivity of questions about contraceptive use at the time. Very good. Nurses' health study. That makes sense. So I know last week was a bit of a downer when it came to some of the OT research and some of the evidence not necessarily supporting some of the things that we used. So I thought I'd have a relevant to you one. So this is, again, from a retrospective cohort study. Who is a better predictor of whether someone will have a failed transition to their home after acute rehab? Medical doctors and nurses, social workers, or OTs? You can probably guess what the outcome will be. OTs are around 4 times better at predicting, actual whether there'll be a failed transition to home. It was interesting looking at the study of the medical doctors and nurses and social workers. It didn't seem like they were any better than random chance, whereas the OTs were much, much better at predicting if we send someone home, who would fail at it. Which is very important, because obviously the last thing you want to do is, when you're discharging someone from a hospital, send them home and then they can't function while at home, because there is a chance that if you send them home, you might never hear from them again because they'll get trapped there or have something bad happen and obviously pass away. So there we go, relevant to you. So retrospective cohort studies, they're much easier to do, which is a pro. So things like which factors predict clients who continue to come to rehab. So if you have a data set where you can see the patients that came back to the hospital or your private practice over the last year, then you can mine that data and go, okay, the people who kept coming back were the ones who are being treated by Ashley because he's such a nice person. Which factors predict poor outcomes? So if you have a database of outcomes of people who've come to your clinic, then you can go, okay, we know what the outcomes are. If we go back to look at data from before that, what actually predicts this? So a key part of that is having things like databases and being able to go back retrospectively through the data. So most, private practice, etc., hospitals nowadays with eDoc, electronic documentation, will have demographics, the staff treating them, what the treatment plans were, initial things like if it's Parkinson's, what their disease severity is, if it's a surgery, when the surgical date was, all this sort of information. All right. So now I thought we'd go through a bit of a, just go through the CASP checklist for these cohort studies. So surprise, surprise, the first question is like all the rest of them. Did the study address a clearly focused issue? Again, PICO should be straightforward. Number 2, was the cohort recruited in an acceptable way? So what is the population and does the sample represent them? So that's where it's really important in a cohort study that you can get good data about the entire cohort. So if you only wanted to, if you looked at a specific subsample of a cohort and then used that data to try and make inferences about the whole cohort, then that's a problem. So for example, and it happens a lot, and we do it in our research just because sometimes you're limited, but if you're looking at people after they've had a stroke and being discharged home, and then you do things like what results in good outcomes with in terms of things like activities of daily living, then you might be restricted to people who have the cognitive capacity to provide informed consent to be in the study. So you'll miss out on a lot of people who may not be able to provide informed consent, may not be able to fill out the questionnaires, may not be able to understand instructions about the things you're doing. So that's where you have to be careful when you're reading these things, going, is what they're doing and their question, can it be answered by the people that they're recruiting for the study? Another big one that pops up, and this can get very tricky, is incidence versus prevalence. I don't know if we've discussed it before, but if we have, I'll go over it again anyway, because it's important. So incidence is when they are first diagnosed with something. So incidence is, this is when the incident occurred, and prevalence is more a case of, do they have something? So incidence is straightforward when it's something like a stroke. So if someone has a stroke, we know the day they've had the stroke. If someone has a traumatic brain injury, like a car crash, we know the day they had the car crash. If someone has a knee replacement surgery, we know the date of surgery. Incidence is trickier with things like, say, diabetes, or again, I'll say Parkinson's disease, a lot of these other things where the day you get diagnosed, well, that's the incident of your diagnosis. That doesn't mean that that's the day you got Parkinson's or that's the day you had diabetes. You can think of, say, two people, one person who's very rigorous about going to see the GPs and getting healthcare, and another person who has, you know, I'm scared of doctors, I don't trust them, and they'll only go and see them when it's worst case scenario and things are falling apart. So they would both have the same day of incidence, but I mean, technically the person who doesn't like going to see doctors, their diabetes might have been rampant for the last 10 years. Whereas the other person, there's a good chance it's only just started because they've noticed something funny and then therefore they've gone to see their GP. So that's where this whole incidence versus prevalence is important to understand, that for things like diabetes, incidence isn't the be-all and end-all. So if a study looks at, for example, we recruited people from the time they were diagnosed with diabetes, that doesn't necessarily make it a better study than another study which just says we recruit people who have diabetes. Whereas if it's something like stroke and they don't actually say any incidence or prevalence data, like they don't say we recruited from 28 days after the stroke, or they don't have information about when the stroke occurred, that's when it becomes a big problem. Because when you have a stroke, you know, the typical rehab process is things go bad and then they go really well for a while and then you'll plateau. So not knowing the date of incidence would be like problematic, like almost to the point of it being a fatally flawed study. If you don't know the time of incidence for a study using people like people living with stroke. Cool. So was the exposure accurately measured to minimize bias? An example study might be, does occupational therapy attendance after hand fracture improve hand strength at 6 months? So the exposure would be the occupational therapist giving out the therapy. So then how would that be measured? So in a retrospective study, you'd have to use whatever data they have. So it might be attendances at the OT clinic. If it's prospective, then you might give them some, you know, mapping. So they came twice per week, and in those 2 sessions, we observed that they did 15 minutes of, you know, interaction with the therapist, 5 minutes of, you know, sitting around, 10 minutes of, you know, filling out a questionnaire or being asked questions. So that way you can have a much better idea about the actual exposure. So that's really important, and I think that's been a problem with a lot of past, like, retrospective studies in the allied health disciplines, is that you might say that someone's had, say, 6 sessions of physiotherapy, occupational therapy, speech pathology, something like that. But if you don't know what's in those 6 sessions, it can be really tricky. So the first session might just be an information session. The second session might be an assessment session. So all of a sudden, those 6 sessions become 4 sessions. And then in those 4 sessions, how much time do they actually get with a therapist? So these things really matter. Another key point, you'll see, do they use subjective or objective measurements? Again, that's a big one. So if it's subjective and we're asking people to rate it, like how was that done? Can we trust those data? If it's objective, were the assessors blinded to it? Was the outcome accurately measured to minimize bias? So for example, was hand strength assessed by asking or use a validated grip strength tool? So again, they talk about the subjective objective assessments, and do the measurements truly reflect what you want them to do? So if we just ask someone about their grip strength and they say, oh, I feel like it's getting weaker, then that's better than nothing, but it's probably not as good as having instrumented data. So if you had someone and compared it to, say, the pre-operative level of hand strength, and it's a wrist fracture surgery, for example, then you'll have much better information than just asking them, because you know they're getting worse, and asking them to grade their, their degree of worseness is probably not that useful. So that's where we need to make sure that the outcome is accurately measured to minimize bias. And again, if someone has the hand surgery, after hand surgery, they'll be like, oh, I'm so much weaker. And then maybe 2 weeks later, because they think they're going to recover, they'll say they're getting better, even if they're not getting better. Yeah. So, and again, did the assessor know which group the client was in? So were the subjects and or the outcome assessor blinded to the exposure? (5a) is, have the authors identified all the important confounding factors? Now, this is, like, I can't emphasize this enough, this is one of the key points, and it's one of the major weaknesses of many longitudinal studies. In case you haven't noticed, I like to read research to get my information on things. Eating eggs, every year it seems to change. One year they'll say eggs are horrible for you, don't eat them. The next year it'll be, it's fine, eat as many as you like. It now seems to be that eating one a day is good, any more than that's bad. And the problem with it is quantifying, consumption of eggs is really difficult, because if you think about the things you eat, you don't necessarily know what's in them. Like, there might be eggs in, the muffins you eat, or it might be egg-free. So it can be really hard to quantify it. So you've got that problem. Then you've got also the other problem of, how do you eat your eggs? So if you eat your eggs fried in a fry pan that also had, a whole bunch of bacon in it, that's different from having, say, a poached egg, or, an egg in a smoothie with a whole bunch of fruit and vegetables. So, and that's where these studies tend to have different findings, and they try and, disentangle the egg consumption from the other poor health. Yeah, that's it, Dan. So how can they determine a problem is from eggs alone? This is the hard part. So there was a decent study last year. It was a very good study last year, published in Journal of American Medical Association, that did a quite good job of it. So they looked at a whole bunch of nutrition factors. So they looked at what their diet was, their normal diet. So things like, basically how well they eat outside of the egg consumption. And they used that as a covariate of it. And they used covariates like smoking, physical activity, all these other factors as well. Because that's the other thing, if you might eat a lot of eggs because you do a lot of exercise and you're trying to build muscle. So that's going to have better outcomes than someone who, drinks a lot of beer and gets hungover, and the best thing for them the next morning is frying up some eggs and bacon and chowing down on that. So they try and disentangle it by adding all these other covariates in, and this is what these confounding factors are. We call them covariates. So all these other confounding factors, you put them into our model and go, if we exclude the effect of all of those, does eating eggs still have an impact on health? And that study did probably the best job it could on trying to figure it out. And it indicated that if you control for total cholesterol, so how much cholesterol you eat, eggs still have a negative impact. And if you control for the health, basically their diet health outside of eggs, it still had an impact once you started eating 2 or more. And it was quite a marked impact as well. So my normal breakfast of 2 eggs with spinach and tomatoes ended up becoming 1 egg with spinach and tomato and mushroom, just because of reading data like that. Once it gets to the point where they've done a really good job statistically and they show how bad it is, and if you have a family history of cardiovascular disease like I do, then you can sort of make these informed decisions. And again, a randomized control trial would be next to impossible to do for a study like that. And that's where something like either a longitudinal cohort study or prospective study, retrospective cohort study with large sample size is needed. So just going back to that example, if grip strength does improve, do we know it's because of OT or was it something else? Was OT only offered to high socioeconomic people who could take time off of work and were less likely to be manual labourers? So using that example of, does OT dosage improve hand strength after, say, a hand fracture? If it's a country where only rich people get healthcare, like America, then you'd probably find, even if OT doesn't work, you'd still find that OT improves outcomes if you didn't have covariates, because you'd have a bunch of rich people who come and get the surgery and then have the rehabilitation after. Whereas poorer people, they might be able to get the surgery, but say their healthcare plan isn't as good and doesn't cover all the rehab. It's just an indicator that they're lower socioeconomic. So they probably have to return to work faster and therefore do more manual tasks with their hand, which may not aid in their recovery. These are things that would be covariates that might be over and above the impact of the actual intervention we're looking at. And that's the importance of the covariates. So 5b, have they taken account of the confounding factors in the design and/or analysis? So it's one thing to identify that there's other things which might have impacted it, and you'll often see that in the limitation section of a paper. So a limitation of this study is that while we looked at egg consumption, we didn't account for the fact of the way they ate the eggs. That's a big problem. But if they identify it and they statistically control for it, and that will be pretty obvious in the papers that they've done that, then that's when this gets the yes. So that's where they talk about things like multiple regression, controlling for cholesterol intake, or controlling for other dietary patterns, physical activity, etc. Same thing with that OT study example. So we wanted to look at the impact of occupational therapy attendance on hand function outcomes after surgery, and we controlled for socioeconomic status, labour force participation in manual tasks, other things like that. That's where you could look at it and go, okay, they've identified these issues and they've statistically controlled for it. (6a), was the follow-up of subjects complete enough? So this is a big one, and I'll use that asbestos example again. So let's just say that there was a bit of a rumbling back in the days that asbestos was causing this rare cancer that was basically killing people very fast once they got it. And they're like, okay, asbestos is causing this. We need to do a prospective cohort study to look and see if asbestos is causing this. If they did a 20-year prospective cohort study, so we looked at exposure to it and then followed them for the next 20 years, there's a very good chance that a study would have found that asbestos does not cause that type of cancer. Because in that situation, the asbestos exposure usually doesn't result in that type of cancer forming for somewhere between like roughly around 30 years post. So in that example, you would think just looking at it, 20-year follow-up, that should be enough. But it's only after the fact that we know or realize that you actually need 30 years. So that's where it's important to look at, was the follow-up of subject complete enough? So if we look at outcomes after, again, I'll use a stroke, for example. If you look at outcomes after stroke, and we only look at, say, 4 weeks after the stroke, then they're still in that acute phase. They're nowhere near the plateau that they reach. So you might have two different people start off with the same stroke severity, same demographics, etc. And then one, their trajectory of improvement is faster in the first 4 weeks. And at 4 weeks, you say they had better outcomes than the other person. But they might actually plateau 6 weeks after the stroke or 2 months after the stroke. Well, the other person might not plateau till 4 or 5 months after and achieve better outcomes. So in that case, and in stroke, we usually say somewhere between 6 and 12 months is chronic. In that case, you would need to follow them up for a good probably 12 months to see what their, I suppose, final outcome was, or close to final outcome. So number 6 was a follow-up of subjects long enough. Again, in some cases, you need a long duration because everyone gets better for a while. So that was that stroke example. So you have a stroke, you know, unless you die or it's extremely bad, you know, typically the recovery looks quite impressive for the first few weeks. And then other situations, developing the disease takes a long time. So we need to make sure that the duration is long enough. So when you're critiquing the paper, that's where you have to look at it, and if you know much about the area, they can get a bit of an idea about the outcomes. So if it's like something like, again, I'll use Huntington's disease, we know that the trajectory from that, it's a long, drawn-out, nasty process. So if you only looked at 1 year and said, okay, they've got a little bit worse, but it's not too bad, then we'd be like, yeah, but that's to be expected. We'd need at least 5 or 10 years of data to be able to identify if, say, a drug was actually beneficial or not over the long term. Number 7, what are the results of the study? So again, this is very similar to other CASPs we've done. So absolute and relative results are preferable. So if you just talk about relative, again, if you report it as a percentage, so one group had 2% more incidence than the other group, we can't use that information by itself. We need to have an idea. If it's 2% more incidence, but it goes from, 1% to 2% or 50% to 100%, these are very different things. And is the difference caused by the exposure big enough to matter? So that's another one, and you'll see this with these studies typically. So if it's, and I keep going back to asbestos because it's a reasonably good example. So if you're exposed to more asbestos, then your odds of getting that cancer are much higher, and you're more likely to have a much more aggressive version of that cancer. So is the difference caused by the exposure big enough to matter? So if someone only had a small exposure, then you'd be able to figure out, well, maybe not. But if they had a lot of exposure, then you could see a very large odds ratio, so a big impact on them. So you could say, yes, looking at that, it matters a lot. Number 8, how precise are the results? So again, we talk about confidence intervals. So this should be yes for most articles. So confidence intervals, if you're talking about odds ratios and those sorts of things, then confidence intervals should be in there. As we spoke about at the start of the lecture, having means and standard deviations, things like mean difference with a confidence interval or standard deviation about it, that is the absolute minimum there should be. We should never be seeing, like, a graph where they have, the mean score for 2 different groups, but no error bars or standard deviations or confidence around it. That stuff is just, it's essentially useless information. Number 9, do you believe the results? So this is one, and I'll use an example. This one fired me up a little bit when I was over in Singapore, because there's the whole fluoridation in water and the impact on babies. So hopefully not many people know about it because you're not into those weird anti-vaxxer type forums, but there has been a big push that fluoridation of water leads to poor health outcomes for children. So, if the mum drinks water in an area that has fluoride in the water, then it leads to cognitive deficits in their babies when they're born. So a study came out, it was a few years ago now, but I was reading it on the plane because I thought it was quite interesting. Actually, that must have been 6 years ago when I was having my daughter. So you read that, and if you read the abstract, you freak out because the results of it were in areas with fluoridated water, then it does lead to cognitive impairments. And then for those of you who have children, particularly the first time you do it, you're onto everything, like everything, you're reading about it all, you're scared of all these things, everything's worrying you. So I read it and I was like, oh no, this is concerning. And you go through it and you actually look at the data, and the data did not support their result. So they basically wrote it up in a way to get media attention, and they were very successful at that. But that's a case of it not passing that sniff test. When I read it and I started looking at it, even without going into details on the data, you could tell there was something really off about it. And there was many flaws in that study, which thankfully have been picked up on. But that's where you can sort of tell, and hopefully once you've read a few articles, which you've been doing now, you'll sort of read the ones where it's coming across as being like a marketing pitch in many ways, whereas other articles be much more straightforward with the data. That's usually a pretty good indication that something's a bit amiss with an article. And then when you start to look at the data and they're showing significant findings, but the impact doesn't look that big, that's when you'll start to go, I don't know if I actually believe these results, and the confounding variables or confounding factors aren't really accounted for well. That's when it comes into play. So thinking about things like, is it due to bias or chance? Are the design and methods of the study good enough to actually detect it? Are there issues there? And then the Bradford Hills criteria. So I'll put them up on the next slide. It's a little bit ugly, but I'll talk through them. So the Bradford Hills criteria was back from I think, was it the 60s? I did have that reference there. Sorry, I didn't include it. But essentially it said, when we look at these sorts of correlation type studies, cohort studies, if it shows a significant finding, it still needs to tick other boxes. So one is it needs to be a strong association. So as I've spoken about before, like there's a strong association between Nicolas Cage movies and number of drownings per year in backyard pools in America. But it's low sample size, the correlation's strong, but it's a weak study. But if it's a large study with large sample size and it has a strong association, then that's a very good indicator that this is actually true. Is it consistent across different populations? So this is something we'd often see in like cohort studies, whereas something would get promoted as being impactful on health in an American study, but then it wouldn't be impactful on health in an English study or an Australian study, but it would be in a Japanese study, but not a Chinese study. And that's when you start to go, okay, is there a good reason for it not to be impactful across those different nations? And if there's not one, that's when it becomes a big concern. Like it might be that it's consistent across, you know, the United States and Australia and England, but that same result's not prevalent in, you know, China and Japan. And that it still could be true. It might just be something to do with diet, because we have a very much westernized diet and they have an Eastern diet and things like that. But if it's not consistent across different populations where it should be, that is another big problem. If it's specific to a certain disease, so that's where that, again, the asbestos example is a really good one. So that became blatantly obvious that asbestos causes that cancer, because it could be made a direct link between that type of cancer and asbestos. So it doesn't necessarily have to be specific to a certain disease, like smoking causes all sorts of problems. Alcohol consumption causes all sorts of problems, from heart disease to cancers to depression to everything else. So again, each one of these factors in this Bradford Hills criteria by itself is not a definite yes. It doesn't have to tick every single box. But if looking at all of these and you look at them and go, well, actually ticks most of those boxes, that's a reasonable interpretation that the relationship is real. The logical timing is a big one. The exposure before the incidents, and I talked about that anti-vaccination study from that Andrew Wakefield, where he made up the data to look like children were getting the measles, mumps, rubella shot, and then within 4 or 5 weeks later, they were having signs of autism that they'd never shown before. So that's what the data he made up, or he you know, fabricated the data, manipulated to show that. But when they went back and audited it, they actually observed that a lot of the children had been identified as having autism-type symptoms prior to the vaccine. So that shot that in the foot. So obviously you can't say that the vaccine caused the autism if the autism was present before the vaccine. So, and that was the death knell for that study and why it got retracted, because of that point. So it has to have logical timing. Another good indicator, it's not always the case, but it's often a good one, is that increased exposure results in worse disease. So, you know, skin cancer, for example, the more time you spend out in the sun, the higher your risk of getting skin cancer. Obviously, there's genetic factors as well, but that's where there's a pretty direct relationship between exposure and indicators of you actually having a worse chance of getting disease. Plausible logical was another one of Bradford Hill's criteria. I'm not necessarily sure that one has stood the test of time, just because of the sheer number of studies which have come out, which are good, strong studies, which have shown the opposite of the whole logic that we typically think. Like heart disease is caused by physical activity. That one's been shot down. There's been a lot of studies recently which have shot down based on the logic. Coherent with what is known about the disease, that's always a big one. So if a cohort study identifies something that is just like completely random to what we already knew about the disease, that's where it can be a bit of an indicator that maybe the variable that they're thinking has caused the disease, for example, might not be it. It might be confounded by something else. Supported by evidence, so if there's other evidence to back that up. So usually, like if you data mine, for example, that happens a bit with that UK biobank, 500,000 people, you can do some data mining and find all sorts of weird relationships. But if you've just picked that out of thin air and there's nothing else that supports it, that's when it's really questionable. But if you find a link between, like, let's say, some kind of exposure to a pesticide and some kind of cognitive impairment, then there's a bit of evidence out there that exposure to pesticides has been linked to increased risk of Parkinson's disease. So it's not necessarily just a random sort of out of nowhere finding. It is backed up by some of the evidence. And being not unique. So similar issues have been observed with other exposures or incidences. So things like smoking causing lung cancer. And like that's one we sort of, we know well now. But then there's been exposure to other sorts of smokes and aerosols and things like that, which cause respiratory problems. So it doesn't stand alone. We've got vaping now, like companies trying to say vaping's healthy. It's like, well, we've got plenty of evidence for smoking and other ingested forms of liquid that, exposure to anything that goes in the lungs, which isn't, clean air, essentially can increase the risk of diseases and cancers. So when it's not unique and there's some good justification for it, that's when it supports the findings. So again, you don't need to tick every one of these boxes, but if it holds up across most of them and there's no fatal flaw there, that's when it can be quite strong. Nearly time for a break. So again, number 10, can the results be applied to the local population? Again, that's where you need to think, who am I working with? Can I apply these results here? Am I in a large hospital with lots of funding and equipment? Am I in a small regional private practice with a very restricted budget on what I can do? Do the results of the study fit with other available evidence? Just because it doesn't fit doesn't mean it's not right. Why doesn't it fit? That's always the important question. Does it not fit because it's just a bad study, or does it not fit because it's actually a really good study and all the other studies are bad? And what are the implications of this study for practice? Are there any at all? All right, that was a fair bit.